Chairpersons, friends, and colleagues, it's indeed a great pleasure and privilege for me to be here today. And we all understand that coronary artery calcification means trouble. It's age and sex related. And when we try to do a PCI in a heavily calcified vessels, there's often complications. During stent delivery, we have problems, and during stent deployment, also, there might be complications like under expansion, asymmetric expansion, etc. So the good news is that in the vast majority of cases, the calcium is usually mild to moderately severe. And with mild to moderate calcium, you can get away with simple techniques like using a body wire, and that helps you to take your hardware like the balloon. And once you dilate your balloon, that acts as a cutting balloon. It's also known as a poor man's cutting balloon, the extra wire, and that works just fine. And while taking the stent, if you have any problems, a good idea is to use an anchor balloon, and the anchor balloon supports the stent. And once the stent is in place, the anchor balloon and the body wire can be removed, stent deployed, and you usually get a great result. So simple techniques that work well. However, when the calcium is more severe, like in this post-CABG patient, all his grafts were occluded and we had to treat his native vessels. You end up using a lot of hardware, lots of balloons, lots of other stuff. The procedure can get very complex. You also need a lot of contrast agent, and sometimes it's very difficult for the patient to tolerate a prolonged procedure. And in this patient, he had severe calcified vessels, and after wiring the LED and the LCX, we first used a taper tip balloon. We then went on to use NC balloons. After NC balloons, we used non-slip elements. At this point of time, we were able to take our IVUS catheter, and we saw that the ostia of the LCX was still severely diseased. So what we did is we took a cutting balloon, a 3 by 10 millimeter cutting balloon, and we addressed the ostia of the LCX with the cutting balloon. And at this point, after using all these balloons, we were able to take our stent, and we took our stents fairly easily. We deployed a 3.5 by 28 drug-eluting stent from left main to LCX. We did proximal optimization, post-dilatation. We then rewired our LED, and we thought that we would be able to take our stent, but unfortunately we were unable to do that. And so at this point, we again took another NC balloon, this time 1:1, a 3.5 by 10 millimeter NC balloon. We did pre-dilatation again, and after this, we were able to take our stent, deploy our stent, do final kissing, to proximal optimization, and the procedure ended like this, satisfactory. But obviously, we had to use a lot of hardware, and it also was a very long procedure. So for heavily calcified vessels, I think it's best to use specialized tools that can address the heavy calcium. And of the numerous tools that are available, I personally think that the rotablation is the most effective. And it is effective not only in short lengths of calcified vessels, but also in diffuse calcified vessels. It is equally effective with narrow caliber vessels as well as in large caliber vessels. So for me, in our center, we think rotablation works well. Like in this severely calcified RCA, in a patient who was on dialysis, PCI was attempted in another center. However, they could not predilate properly. So this patient was sent to our center, and 2 weeks down the road, we did rotablation. So we started with rotablation. We first used a 1.5 millimeter rotablur, and then we stepped up to a 1.75 millimeter rotablur. And as you can appreciate, we did rotablation through the entire length of the RCA. After rotablation, we did a thorough job of pre-dilatation using 2.75 and then 3 millimeter NC balloons. And after that, we took our stents, and we deployed them. After deploying our stents, we did post dilatation, a thorough job of post dilatation as well. And this is the final result that we got after post dilatation. And you will surely agree with me that if we had not used the rotablator, we would not have got results like this. Now, this last case is an 82-year-old, very frail lady with multiple comorbidities who had to undergo PCI because she had very severe coronary artery disease. And considering frailty, it obviously has stages, and she was way down the road. And the problem with frailty is that you cannot treat it overnight and correct it. So we had to deal with this frail lady, and one way of dealing was to stage the procedure. So we first did the RCA, and only after 4 or 5 days did we go to tackle the left side. Now, if you look at the left side, you know from the very beginning, this patient will need a double stent strategy, no doubt about that. And also that she's not going to tolerate any prolonged procedure, lots of balloons or anything. So from the very beginning, we used rotablation. We first did rotablation from left main to LCX. After that, we did rotablation from left main to LAD. We had a look with our IVUS catheter, and we found that there was still a lot of calcium left. So what we did is we stepped up our burr and we used a 1.5 millimeter burr. After rotablation, we went on and we did DK crush, and she tolerated the procedure very well. And with DK crush, what I feel is that it's just like following a recipe. You do one step after the other, and you hardly need to use any contrast. So after the DK crush, this was the final result that we got. So rotablation, I think, is great for diffuse, severely calcified vessels. And I would like to share our experience with rotablation at the National Heart Foundation Hospital and Research Institute. Now, from January 2015 to June 2021, we've done a total of 288 rotablation cases in our center. And you can appreciate that 73% of these patients were above the age of 60, and 31% of these patients were above the age of 70. Around 27% of the patients were female, the rest were male. And these patients were really sick. They had multiple comorbidities. 91% were hypertensive, 64.6% were diabetic, 63.9% had some stage or other of chronic kidney disease. And if you look at the type of lesion, 86% of these patients had long, diffuse calcified lesion, and the mean lesion length was 46 millimeters. And around 215 of these patients were really complex cases. Like we had 104 left main cases, we had CTOs, we had post-PCI, all very complex patients. And we did a single vessel rota in 82% of our cases and doubled rota in 17.4% of our patients. And if you consider percentage-wise, the patients where we did LARPO rota had more bifurcation lesions, had more of osteal lesions, and more of left main coronary artery disease. Now, we've managed to follow up all these 288 patients, and our mean follow-up is 32 months. And you have to remember that these were elderly patients. 31% were above the age of 70. Most of them had multiple comorbidities, and they had real severe disease like left main, CTOs, etc. So considering all this, it's really great to know that 83% of our patients with this mean follow-up of 32 months are doing well. Our overall MACE is 16 and our death is 15.2. Now, regarding the death, I just want to highlight that 61% of our death is non-cardiac. And these patients have really been hit hard with the COVID, and quite a large number of patients died due to COVID-related incidents, and the main deaths have occurred in the last 1.5 years. So we have managed to publish our findings in a couple of journals. And in summary, we would like to say that usually patients with calcified vessels tend to have multiple comorbidities. Their vessels tend to be often diffusely diseased of narrow caliber, and we think that ROTA is an excellent tool to tackle such severely diseased, diffuse, narrow caliber vessels. And the most important ingredient for tackling such complex patients is the teamwork. And from the entire team of National Heart Foundation Hospital and Research Institute, Dhaka, Bangladesh, I would like to say thank you for giving me this opportunity to present our experience. Thank you.